Hi, and welcome to our audience. I'm so glad that you have joined us today. We have another shop talk for CMET, and we are excited to introduce to you Dan Rhon. He is a colleague, a friend, and a great resource for manual therapy conversation. So welcome, Dan. Thanks for coming on.
Awesome. Thank you so much for having me. I'm really excited to spend a little bit of time with you talking about this topic.
Well, our topic today, guys, is manual therapy, always a passive treatment with a question mark. So this paper was published in JOSPT in 2021, the fall. And so if you haven't taken a look at it, I'd encourage you to do so. But we're going to have a little conversation today to brief you on this topic and get to know a little bit more behind the paper. So that said, Dan, could you tell us a little bit about yourself, your current role, and your background as a researcher?
Yes, of course. This is probably the most challenging part of the talk here. So I'm a physical therapist, and really I started my career in the military. So I was an Army therapist, physical therapist. I went to school through Baylor in the military, and then I spent some time deployed as a PT, and then eventually retired from the military. But near the end of my career, I became a researcher, was able to go and get my doctorate. And now I actually have transitioned out of the military, but I still continue doing research full time for the military. So I'm a professor in the Department of Rehabilitation Medicine at the Uniformed Services University of Health Sciences in Bethesda, Maryland. And I do most of my work at Brooke Army Medical Center in San Antonio, as well as a couple of other gigs here and there. But that's my primary focus. So I'm primarily a researcher now, and just really enjoy what I do.
Excellent. So then the next part is that this is a viewpoint paper, and it's a little different than a traditional paper. So I'm going to ask you just to describe what this viewpoint is so our audience is aware.
Yeah, so a viewpoint is intended to be more of an opinion piece, if you will. So when you read this, just keep this in mind. This is not a hypothesis generating research question that we tested. It's not an objective piece of science. It really is it's a viewpoint. So it does sort of lean in one direction towards what somebody might be thinking. Anybody else could write a viewpoint sort of outlining the opposite side of this, the opposite rationale. So this is really an editorial and opinion piece, if you will.
Great. So Dan, what prompted you to write this viewpoint paper, manual therapy, always a passive treatment?
Yeah, so that's a great question. I think over the last probably 15 years, we've just seen this label of passive therapies that has emerged, and we've used it in physical therapy as really to highlight care that is suboptimal. So we talk about modalities, which we don't recommend as first care options for a lot of treatments. So a passive intervention would be one that where the patient really doesn't take a role in their care. And we've seen slowly manual therapy sort of transition under that label. And so it's happened slowly, I think, because now that wasn't always the case. I was looking back at some earlier papers, and that line was a little bit grayer. But now I read quite a few papers that will talk about passive interventions in sort of this negative light that are not recommended, and then it just slips manual therapy in there. And so I think it's a lot more nuanced than that. I don't think it's just a black and white, this is where manual therapy falls. Manual therapy is just a very broad, can be a very broad topic as it is. And so we felt compelled to put these thoughts down on paper, just because we'd been hearing these arguments, and people didn't really know how to respond to that. So at least this is our perspective and our opinion on how to handle that piece, that manual therapy is always a passive intervention.
Well, that is a perfect segue to my next question, because you've described a lot of your rationale, but how would you actually describe manual therapy?
Oh man, see, that's the magic question, that I say that because I think we really have struggled. We've put out papers, and because it isn't just up to me to define that. You know, we have APTA definitions, we have IFOMP definitions. We look at cross various papers, and so sometimes it's you know, a hands-on approach that includes massage and you know, chiropractic and even dry needling falls under that label. So it's very, very broad. But I think the problem or the challenge with that is when we're using one label to describe a whole variety of interventions, that we're going to come up into a bit of a challenge. In the paper, you know, we defined it as a synergistic application of movement-oriented strategies, which include exercise and manually applied joint and soft tissue mobilizations and manipulations guided by a clinical reasoning framework that informs dosing and progression of all components. That's more along the lines of the manual therapy that I learned. It wasn't just a, here's these, this is how you move the joint, and then that's how you treat someone. In fact, we would always argue that doing that component with the exercise is what makes up manual therapy. If you're only doing exercise, it's great, it's exercise. If all you're doing is wiggling the joint, if you will, that was never expressed to us as being manual therapy. Without that exercise component, without that active component, it really wasn't the intervention that, you know, we were learning. And so when you read these sort of watered down definitions, you know, the first thought is like, well, that's fine, but that isn't exactly what we delivered, or that doesn't seem like a fair label or title for what we were using. We're really comparing apples and oranges if we're saying that both of these things are manual therapy.
Yeah. So in the same paper, right, you talk a little bit about the complexities of low value care versus high value care. And how can manual therapy be one or the other?
Yeah, that's a great question, and I think this is where the nuance comes in, and what I would hope comes across and gets clinicians to think about that. A lot of these questions and these issues we have, we tend to want to come up with very simple answers for complex problems, and so it's easy to just say manual therapy is low value, it's passive. That's sort of how this has come around. So we label passive interventions as typically low value. We know that, you know, if all we do for someone with back pain is put hot packs on their back and give them TENS, that maybe they'll get some short-term pain relief, but it really doesn't improve things in the long term. And so that's considered low value care. Active interventions, exercise, getting them engaged, those things are high value care. Those are the things that have larger effect sizes in trials. So then when you put manual therapy, because the idea is the patient, that I've heard at least from a lot of people that put this under that passive intervention, manual therapy under that, is that patient's just sort of laying there, they're not involved in the process. You know, you're doing something to them and they're not an active participant. And so it's considered passive intervention, and therefore it's low value care. So, you know, it's kind of that straw man. Whereas if we can determine that manual therapy is passive, then we can, and because passive care is low value care, then by definition or by deduction, we can say that manual therapy is low value. And so I think that's the challenge there, and just getting people to think a little bit differently, that maybe it's not as simple as that is. It's a little bit more complex. So I want to give a couple examples of how why it's complex, because manual therapy can definitely be low value care. And so but I just want to throw this out. So can a lot of other interventions. So we know exercise is great, and it's one of the core treatments for a lot of interventions. You know, knee osteoarthritis, exercise is a core intervention, meaning that should be at sort of the root of whatever they get, should be in addition to exercise. That's a core intervention. But just because it's exercise doesn't mean that it's high value. You can give somebody a very low value dose of exercise. So just that label alone doesn't put it into this category of that's great. You know, I can tell someone they need to do, you know, 5 squats every week for 3 weeks. And then if that doesn't work, it's like, oh, hey, you did exercise. Well, I would argue, the dosing is wrong. There's a lot of pieces there. I'm not looking at the progression. That's exercise. That's low value care. You can deliver manual therapy in the way that I described it, in a very in a manner that facilitates exercise, activity, function, where the patient is very engaged, with clinical reasoning driving the process. And I would think that would be a high value care. But I can, and I know this does happen, I'm not naive to this, you can have low value care where maybe you come in and maybe you provide a manipulation, or you just mob the knee a little bit and then you put some hot packs on it or some ice. And there's very little focus on what that patient really needs. And so I think that same intervention can be both low value and high value care at the same time. And so I think those are examples of the nuances of this, and why we have to look past the label and really try to understand what goes in there. Just don't be resist the temptation to simplify the intervention down to this simple label alone.
And that's a great point. And I think some of that maps onto my next question, which is, what are some of your biggest challenges with some of the current assumptions on manual therapy?
Yes. So I think some of the biggest challenges revolve around this label. When I throw that label out there, it depends who I'm talking to, right? If I'm talking to someone that's doesn't really care for manual therapy, a clinician, those two words, manual therapy, they'll contrive certain thoughts and ideas in their head about what they think manual therapy is. But at the same, on the same side, if I'm then talking to someone that is very much an enthusiast of manual therapy, they'll have a different perspective and thought. And I'm not saying either one is right or wrong. They're just very different. And so when I am trying to promote this for the use in one of my trials, and I'm trying to promote, high quality care, like we showed in our New England Journal of Medicine trial, where we compared steroid injection to manual therapy. Of course, I'm a big advocate of high value care. I'm not interested in delivering low value care. Like, that would just be a waste of time and resources. I'm delivering something that I think that there's some value in. We want that to represent what we would think is high value care. So it does take, even in those circles, it does take some education, some conversation. Like, let's break down what we consider to be a high value manual therapy program. What does it consist of? And I think that part is important, very important. I think we need to, as researchers, be careful and be diligent about describing very carefully our interventions so that they can be reproduced appropriately and adequately. So that when someone reads my trial and they say, oh, this was effective, in their mind, they see manual therapy and they are delivering it one way, and maybe it is low value, and someone else in their mind sees it a different way. They both see the same label. So how can I describe that better? So whoever's reading it can see, like, oh, this is what they did, and to try to get similar results.
Right. And I really appreciate the way you approach this kind of in a non-binary, like manual therapy, good, manual therapy, not good, manual therapy, high value, manual therapy, low value. You've really mixed it where you're saying it's more about the application, recognizing that these assumptions do exist, right? And to really create this non-binary option, I think is really important. So I appreciate that. And so then my next question is then, what suggestions do you have for other researchers and investigators? What are a few just critical things that you think that they should consider before conducting or designing a clinical trial using manual therapy?
Yeah, that's a great question. And I think realizing that coming up with a universal consensus on the definition of manual therapy is, that's a tall order, and probably not something that is likely, to occur anytime really soon, that everyone's going to be on board with. What I think I would really recommend and have them label and define that intervention really well. So what is it really that you're looking at here? And you can call it manual therapy, but the practice of publishing your protocol ahead of time that outlines everything that you did and your process, that can even be done, with very little effort on like the open science framework, or on protocols.io. You can get a DOI number and it can't be changed. Like there's all these things that can be done to share more of this information with individuals. And I think that's really important, because we're really looking at replication, the ability to replicate some of these studies, the ability to validate some of these studies. And there's a lot of systematic reviews over the last 5 years that have been very limited in their ability to compare studies, because authors have been, or researchers have just done a really poor job of highlighting these details. And so those that are reading the papers, or the clinicians, the researchers that are trying to replicate these, have really been challenged because they're not able to with the information that's provided. So that's what I would say, is provide good, clear definitions, let people know what you're doing, and make sure that that is maybe a bigger focus than just the label alone.
And that's some great advice for our researcher, investigator audience. So now I'm going to transition to the other side of our audience, which is to our clinicians. And we have such busy clinicians that work so hard to really translate evidence into practice. And so what are some of the takeaways that you hope that they will walk away with from this viewpoint?
Yeah, so that's a great question. What I would say is, don't let your identity, be careful about letting your identity be wrapped up in being a manual therapist. I think it's a very powerful intervention, and I think it's great. But I think we have to go beyond that. And it's very easy to just look at that label in the same way, read this. And if it doesn't align with our biases, we kind of throw it out and say, oh, well, whatever. And if it does, we say, great, this is good. Instead, this is how we can learn the self-reflection that takes place. Dive in, look at how they're delivering that manual therapy, and interpret the results within the context of how that intervention was delivered. And then that's where there's a little bit of time for self-reflection. Does this align with how I'm delivering manual therapy? Should it? What could I be doing differently? Look at the time that was spent with patients, the clinical reasoning aspect of all of this. And there's a lot there. And then the second thing I would say is, I've just seen a lot of clinicians sort of struggle with this. It's almost like a bit of a shame that you're delivering a passive intervention. So you get shamed for delivering something that's passive manual therapy, and they don't always have a good answer for that. And so I would say is that, first of all, the term passive intervention existed way before it was used for physical therapy. And so it's not a very clear cut definition. In fact, in my sort of research for this paper, I found a lot of other uses for, passive intervention is used to describe education that is provided to clinicians. And we wouldn't say that, or to patients, I'm sorry. We wouldn't say that that's low value. I mean, it could be, again, it could be low value. It could be very interactive. Medications in, mental health and psychiatry trials are considered active or passive interventions. The ones that are inert, the ones that are actually have something in them of their therapeutic, those are called active interventions, even though it's still a medication that the patient takes. So there's a lot of, we don't own this label. We sort of stole it, and there isn't a consensus on what it actually means. And so just take heart that these are the quarrels that sometimes we as researchers and academics like to have more than anything, because it makes us feel good to argue these things. And I think just keep striving to do the right thing, to learn, to grow, and realize that it's a little bit gray when it comes to those labels, and look beyond the label, look beyond the identity, and continue to strive for what can I do to help my patients get better, and just sort of ignore that other noise. It's nothing to be ashamed about. It's a lot more nuanced than it appears at face value.
Well, Dan, if the audience enjoyed listening to you as much as I did, I'm sure they'll want to read more of your work. So where can they find your work? Where are your social media handles, and how can they find you?
Yeah, so probably the best way to interact with me in terms of research and education on the sort of academic side is on Twitter at Dan Rhon. Really simple handle. I usually push out papers when I publish them there and engage with other authors about questions that come up. That's a great place as well. And then all my stuff is. I think I'm still the only Rhon in PubMed. You know how there's like when I type in Rhon D, like there's no other Rhons in there. So eventually, maybe if I have really smart kids and they start publishing or something. But anyway, so that's where you can find a lot of my other publications. But I say Twitter is a good place to start.
Well, awesome. And thank you, Dan. On behalf of CMET, we hope our audience enjoyed this shop talk and learning a little bit more about your viewpoint. And you know where to check us out, and look forward to our releases as we interview top-notch researchers doing great work. So thanks, Dan, for your time today.
Awesome. Yeah. Thank you for this opportunity.